Thank you. So good morning, everybody. Welcome to March's meeting of the Humber and North Yorkshire Integrated Care Board in public. Welcome to everybody in the room, people who've joined us in the room and people who are joining us on screen as well today. We do have a couple of people who are not here at the moment, and that may be because I think there's some traffic kind of issues, so they may arrive during the meeting. So on the screen, just for reference, we've got Louise Wallace, Director of Public Health, and we've got Yvonne Elliott representing community providers sitting on the screen, and everybody else kind of is in the room. And just a reminder that this is a meeting in public, not a public meeting. Really welcome those people who have come to join us today and those people joining us on the screen. There will be an opportunity to observe the business of the ICB, but actually there won't be the opportunity to ask questions during this public part of the meeting. So in terms of just kind of going through apologies, so we have apologies from Sean Jones, but Sean Lockby, which makes it easy, is going to represent Sean Jones. I wish this happened all of the time. We've got apologies to Amanda Brew, but Yvonne is on the screen. Alison Barker, who has a government department visit today, is apologising. Merlin Joseph, one of our children's services representatives, is also apologising, and also Tracy Myhoff, one of our adult social care representatives as well. So they're the apologies for the meeting. And just for noting is the register of members' interests in terms of this particular meeting, and also the register in terms of gifts, hospitality and sponsorship, just for transparency. So if we move on to the minutes of the previous meeting, which was the one we had in public on the 14th of January, we go through for corrections and accuracy, and we'll pick up matters arising on the action list. So pages 1, 2 and 3, 4 and 5, 6 and 7, 8 and 9, 10 and 11, 12 and 13, page 14. Are there any corrections or accuracies that anybody wants to add to those minutes? So is the board happy for me to sign those as a true and accurate record? Yeah. Superb. Well done, Michelle. If we move on to the matters arising from the previous meeting, which is the action list, which is the back of the minutes. So the first one, and this is one you probably can't answer, Sean, in that we had the presentation last time, I think, from Amanda on corridor care, and we asked for just an understanding of some of the metrics that sat around corridor care. Have we managed to do that?
I have spoke to Sean Jones and I spoke to the BI team about this. At the moment, we haven't got a list of them and they're not being reported. What's happened is the corridor care, there's a new nationally defined corridor care metric that's replacing the temporary escalation space measure. It is now being captured as the data. It is being reported through the daily sit rep. So every day hospitals are submitting this data into the centre, but it is not being released for us to analyse or review yet. The deadline, well, they're expected this to initiate from May this year.
Okay.
So next month we'll be able to give a clearer update, and the month after we'll be able to give you numbers.
No, that's really good. That's very helpful.
Can I just check, Sean, does that mean we will get it from national back to us rather than direct from our providers? Because if that's the case, there will be a significant time lag, won't there?
So the daily sit rep goes in every day, goes in centrally, and we get it the day after. We access it centrally.
Okay, so it's not actually, it's not a meaningful time lag.
Okay. On daily sit rep.
Okay.
So it'll be an added field in that.
Yeah, so it'll be near enough to real time as we're possibly going to get. And
as good as what we get on ED now.
Yeah, that's fine.
That's really helpful. That's really helpful. So, and I suppose we just need to think about incorporating that into future kind of reporting to the board.
Yes, that's in train, and we met with the we met with all the chief nurses across our system the other week, and this is going to be one of the priorities that we're going to work on, with a narrative that actually we do not have corridor care, and I recognise that that's very easy to say and it's quite complex, but actually it's putting a marker in the sand to say we don't want any patients being cared for in a corridor, and we need to work towards that.
Okay, and that's helpful, and that data, that reporting will help us in those conversations, won't it? So So we can take that one as closed. So the second one was also for Sean, which was around risks and mitigations to be recorded and monitored linked to emergency preparedness, resilience and response core standards. And I think that was linked to the report that we got, wasn't it?
Yes, we had a report, and the report listed some of the risks, so I'm not quite sure.
So I think this was more about how do we monitor the, in terms of, so we agreed the risks and there were actions. So how is the board then assured that the actions are taking place to mitigate risk? I think that's what this one was about.
Okay.
So I went through these actions with Sean, and he weren't sure that as an exact action, but he did say that we can bring back regular updates on the progress, because the EPR team do track all of the outstanding gaps, and they're working with providers and ourselves, our board, to make sure that those actions have all been implemented or mitigated. So if what we need is periodic updates against the missing actions, we can do that.
I think it'll probably be helpful. We just probably need to think about that, Jane, in terms of the board work plan, kind of moving forward. So that's really helpful. You'll be pleased to know that the next one isn't yours, Sean. It's for Nigel. Yeah. And this was around the risks flagged by Digital Data and Innovation Group. And I think that was the ongoing kind of risks around organisational change and digital, which the position on digital is one of the ones that has shifted quite a lot in the period between the and where we are now.
Yeah, thank you. So absolutely, Chair, those things have changed. What hasn't changed is probably understanding where things will lie and sit in the new world with regard to national, regional and ICB. So what we've been doing, and John was in the audience, is looking with region about who does what to reduce duplication and make sure that we're doing the right thing at the right place. So that's ongoing at the minute. We also, as the board will remember, have got some system level priorities around digital. What we've been able to do for that is to share those responsibilities out amongst the wider CIO community of the system, which is really positive and sort of lends itself to the system working that we've really put in with digital. And the last thing is we've got the last Data Digital and Innovation Group on Friday to go back through this and to make sure that we've looked at all the risks and mitigations and closed down everything that we need to. And then that insights report will come to the next board.
That's really helpful. And I think part of we'll touch on it later in terms of the, preparing for the new world, we'll be kind of looking at the governance that we need to put around some of those core things that we need to be moving forward. So, we will still need to have a way to get assurance and to flag risk, from our perspective moving forward, but it might be different to what we have today. So that's helpful. So I think we're closing down all of those actions, Michelle, if that's fine. So notification of any of the business. So there is no any other business that has been flagged for this meeting. Move on to questions from members of the public. So we had one question that was kind of raised within the time frame for consideration of this meeting. Nigel, I think you're going to pick this one up because it's to do with ADHD and autism, isn't it?
Yes, thank you, Chair. So thank you to the member of the public who has submitted this. And this is a question around how we work with patients and residents with lived experience when we're looking at commissioning our services. And what we'll do, and we have done, and there is a response that we will put out with the minutes of this, is around how we are approaching this and have approached this over the last 12 to 18 months, but then going forward in our new way of working, how this is a continued priority for us around ADHD and autism. What I can say specifically for North Yorkshire and York is that both local authorities now have new autism strategies in place. And in York, there's a dedicated autism strategy group focusing on the delivery of actions and monitoring programmes. And in North Yorkshire also, there's a North Yorkshire Community of Interest group supporting the delivery of the autism strategy. And the reason I pull those bits out is that this question was specifically asking around those areas in North Yorkshire and York. What I would say, and I have spoken to Michelle about it, is that everything that we do within mental health and looking at those services that we want to commission or commission differently, we do look for experience from patients and residents with lived experience, and that continue with our new way of working going forward.
That's really helpful. And I think, I certainly met recently with our patient engagement network, which was probably one of the most challenging kind of sessions I've had, kind of talking about the new ICB structure and new ways of working. But I think one of the things I had the opportunity to talk about was, if you recall, in our programme of care structure that we're talking about moving forward across all of our commissioning areas, I've talked very much around the importance of reference groups that kind of bring together providers, patients, and very much that whole element of the insight element, patient experience, should be driving our kind of commissioning the new world. So I think very much there is an opportunity we have to talk to people who use services, non-sector groups and organisations, our providers, our existing patient engagement network, in terms of driving forward not only the priorities for this organisation, but also what we deliver in the future. And I'm very, very positive around the opportunity we create with that as well. So I think we will pick up some of that through the work around the mental health and disabilities and neurodiversity kind of programme of care. And I know it's something that Michelle has got to bring you in and say from your point of view as a mental health provider.
Thank you, Nadia. And we have had a brief discussion, but what a great question, really. And I think it forms a lot of the questions about everything that we do, really, not just particularly around ADHD and autism, that it's exceptionally important. And I can speak on behalf of our organisation in relationship to East Riding and Hull. We've got a really active PACE forum, patient, and that includes voluntary sector as well. And we do try and co-produce all our pathways and care treatment plans. I think sometimes it's probably not enough. I think we can always do more. You can always say that you can do more, and sometimes it's not seemed to be enough, and there's so many groups out there that it's really difficult to cover those. From a North Yorkshire perspective, my organisation to provide that service, I think it's more difficult to comment on that, but as the lead for the collaborative, we are doing more and more that we can in relationship to involving service users and carers and people with lived experience, as well as the local authorities and et cetera, et cetera. But it's a vast area and it is difficult. So I'm not saying we've got that right. So all we're saying is that if people do want to contact us from the collaborative point of view, we will try and explain what we're doing and also give them links into what we're particularly looking at the moment. But particularly the neurodiversity piece is really topical, and any help and support we can get will be gratefully received. But great question.
Thank you, Michelle. Stuart.
I'll ask a question. There's a paragraph in the middle of this question about updates through minutes and reports gleaned from Freedom of Information requests. And it talks about spurious reasons given to reject disclosure and MP requests being ignored. Have we explored that? We're surely not giving spurious reasons, are we?
No.
And are we ignoring MPs?
Well, no, we're not ignoring MPs. We meet regularly with the MPs. So I don't know. If I'm honest, Stuart, I don't know what that.
So we'll respond in some way to that.
Yes, and we can
as well as sort of
and I think what we're describing is a new way of working and a new set of kind of relationships. I think very much. I think Michelle's right. That there is still more to do, but I think we have a greater opportunity kind of moving forward to have a wide collection of voices, which are going to be really important to our strategic commissioning function kind of moving forward. Okay, and the second question for you, Nigel, was around measles vaccination levels.
I thought we did.
No, so this is one that came in but out of time frame. So we've responded to it, but we haven't yet received it at the board. So that is why it feels like deja vu.
It does. And apologies, I didn't realise that we were responding to this one. But yes, I absolutely understand this. So as colleagues may know, the MMR programme is an NHS England commissioned programme. But what we can say is and give assurance on some of the levels of vaccination that we're seeing across our 6 places. What I would say, and I did say in the previous board meetings, and I've probably said it everywhere I can, is vaccination is one of the most important, if not the most important thing that we can do for health protection now and in the future. And so I would implore everybody who has needs a vaccination that they go and get it. And it's really, really topical at the minute because we have measles at the minute in our area. And we know that it is one of the most contagious infectious diseases. So I would implore people to get themselves and their loved ones vaccinated and immunised at every point that they can. I don't know whether Amanda, is there anything else you want to say?
No, I think that's the key message, isn't it?
Yeah.
And as soon as we talked about health protection, I anticipated the hand from Louise Wallace, and you didn't disappoint, Louise.
Jolly good. No, obviously, Nigel, completely right. And just to give reassurance, because there is reference to Director of Public Health in the paper, that we are absolutely vigilant on this and working together with the UK Health Security Agency wherever and whenever we see cases of measles. And of course, we just want to make sure they don't occur. So yes, please get vaccinated. And of course, we will be there to respond collectively to make sure the public's health is protected. Thank you.
So thanks, Louise. Lynn, and then Michelle. Lynn.
Thank you. So I recognise we're not doing a big campaign at the moment, but I wondered, Nigel, if there's anything that we can do to support the the promotion of vaccinations through ED. Are there any pamphlets? Is there anything that I can say in my weekly blog to reinforce that? Because it's so important. And unless there's a campaign and it's front and centre, people get distracted with other things. So it's just an offer to do any help that we can through our different routes in the acute environment, and particularly through ED.
That's really helpful, and I think we can probably pick that up, can't we, in terms of what we do.
Yeah.
So Michelle, then Stuart.
Yeah, that follows on from Lynn's point, actually, just to remind the board, I think we have mentioned this, that our organisation, Humber Foundation Trust, Teaching Trust, are part of a national pilot for our health visitors to be doing measles in the home. So please, if there's anybody either at home or reading the papers or whatever that's interested in that, particularly in the Hull area, then we will be vaccinating people either in the local baby clinics or in the home. And it's quite a national first, because we were wondering how that would work, and at the moment it seems to be exceptionally well received. So it is very, very innovative at the moment.
Thank you.
We've got all our health visitors and nurses by background, so we might as well utilise the skills there.
Okay, Stuart.
I was looking at the World Health Organization saying 95% levels of vaccination were a good idea, and then staring at the statistics, which suggest that East Riding, possibly apart from that 5-year column, but East Riding achieve it, and some other areas don't by some significant gap. East Riding doing anything that we can copy in all the other places?
We don't know specifically, but we can.
And I think it's an interesting point. I think just building, what people have said, and I think Michelle's point around, vaccinating in different kind of settings. I'm recalling Annie's presentation a couple of meetings ago where we talked about those pop-up hubs and around actually the opportunity we had to particularly people who were vaccine hesitant, to actually find a different way to have the conversation around vaccines and the success of that. And I think, very much today's meeting is kind of straddled a bit between current ICB and new ICB, but the opportunity I think we have, thinking about neighbourhood health in particular, kind of moving forward, is going to be really important, isn't it, Teresa, I think?
So, Stuart, just to, I think it's an interesting point if we were to map across to deprivation statistics. So the area that I would be particularly interested in understanding what they're doing is actually North East Lincolnshire. Because if we look at the mapping of deprivation, they are doing well despite where they appear on the deprivation statistics. So that might be something for us to explore.
Yeah.
Okay, brilliant. So, and just to say, we've had another couple of questions that were submitted outside the timeframe for board questions. We will take those questions at the next public board, which will be April, but we will be responding to those people who asked the questions in writing before then. And the responses to both the questions we looked at today will be on the website after this meeting as well. So thank you, and please keep asking questions. I think it's a really helpful conversation we've had around some really kind of key areas of work. Okay, so we're going to move on to the board assurance framework. So this has got my name against it, but I'm going to look to you, Jane.
I'm happy to take it.
Yes, I suddenly had a momentary panic there around this.
This is a verbal update for everybody. So rather than bringing the BAF here. So we've got the preparations ongoing for 26-27. That remains on track. that's the year-end BAF analysis that will come to the meeting in April. We've got Q1 where we'll focus on a full technical review of the BAF, including alignment to the new strategic objectives as they are developed. That will include refreshed statements, controls, assurances and the ownership. When we've done the review of the individual risks at the committees in Q1, the draft 26-27 BAF is going to be brought in full to the private board meeting in June for comment ahead of the formal launch and approval in public at the July board meeting. And then an assurance paper on the risk management next steps is going to the audit committee on the 18th of March as well around the BAF. I think that's most of the update.
Okay, so very much what I'm kind of hearing is that there's a close down of our current BAF as we would expect at the end of this year, and actually audit got a clear role in terms of that, but then actually the work starting already on what the new BAF will kind of look like.
Yeah, absolutely.
Okay. And I think that final tidy up of the BAF, I know that all the committees have been asked to kind of review their elements of the BAF, and thank you to everybody who responded to that as well. I think it's a full set now. Lynn.
Thank you, Jason. I'm just wondering, as you close down one, you move to the new BAF. In the new BAF, how are you going to mitigate that risk in relation to the change in makeup of the constitution of your board while still retaining good partnership and collaboration?
Yeah, that's a cracking question, actually, Lynn, and one that's incredibly difficult to answer until we've done the work that we're doing in Q1, but we will definitely be speaking to partners about it as well.
Yeah.
We've just recently had significant assurance on the way that we approach our BAF in the ICB, so we're confident that we'll be able to manage those effectively.
Right.
I think
it wasn't meant to catch anybody out. It was just a genuine desire to build on what you've done so far, but with the change in constitution, I think it might play out differently. Thank you. Sorry, Jane. Thank you.
No. I think it will, and I kind of think, my reflection is at the moment we have a board assurance framework that is straddled between a system board assurance framework and an organisational board assurance framework, which is interesting but not always entirely helpful. I think this probably takes us to a point where we are looking at the BAF from a strategic commissioning organisation perspective, which actually I think narrows some of the focus, but probably sharpens where the BAF kind of needs to be. But that doesn't take away that ongoing commitment that we cannot deliver anything as a strategic commissioning organisation without a strong emphasis on partnership and relationships. And actually that is, and we'll touch on that, I think, a little bit when we start to talk about the future organisation later. But I think it's a really, really good point that the BAF will need to look different for a different organisation. And there is an opportunity to make sure it's the right things on the BAF that we can measure and the board owns. I think that's important.
Thank you.
Okay, so we're going to move into your governance section, Jane. Yes. So some of this is straddled between new world, old world, but we can navigate ourselves through this, I think.
Yeah, we can. Thank you, Chair. So the first item, which is 8A in your pack, is the Constitution and the standing orders. You've got 3 items to consider. You've got the covering paper, and then you've got an Appendix A and an Appendix B. The paper itself is really very self-explanatory. Appendix A gives you the summary of all the changes, setting out what's affected, what current wording we've got and what the recommended amendment is. And Appendix B is just the full Constitution document for you to consider. There are some key changes in there. So board membership is changing, titles of roles, which we've reviewed against the structure that we're currently in the process of implementation on, the revised quorum, and the removal of the non-mandated ICP references. That's come out. So the bit that I would probably like to tease out is ordinarily the audit committee would see this before it comes to the board, but because we need to get this approved for the 1st of April and NHS England have agreed that they can approve it by the 1st of April, we've brought it here first. But to give you some assurance, both the chair, Jason, you, and Stuart as the audit chair and the executive team have gone through this constitution, and therefore it is recommended for the board to approve. And as I've said, NHS England have confirmed they can approve the document by the 1st of April 26. The last point to probably tease out is we're still waiting for national guidance on constitutions for revised ICB structures, so that it will come back around again at some point. But at the moment, that hasn't been released. So this is the constitution that I would recommend to the board to approve, to enable us to send it to NHS England for approval.
It means that this constitution becomes effective as of the 1st of April as well. So actually, we are constituted to operate from the 1st of April. Stuart.
Well, partly just to confirm, I did look at it, I thought it was sensible. The other one is just that there's potentially a period from the 1st of April to whenever you've filled all these posts where it's going to be difficult to comply with this. You got any comments on that?
So sorry, I was just going to ask for a clarification. Are there specific posts that you
Well,
are?
I'm thinking of 6 non-execs.
Yes, I thought that was the case. That's why
I think most of the other posts are already filled or
yeah.
So we will be. So I was going to pick up in my update, but I'll take it now. So we are in the final stages of the appointment process for the 6 non-executive directors. We should have approved those appointments by the end of March. So we will have names in the frame, and we have agreed that the April board meeting will be towards the end of April rather than the start of April, because we were unhelpfully going to be in Easter week, which I imagine would be difficult for some people, which means that we've got opportunity in terms of just to tidy up that. So actually, effectively, the board will be in place, for the end of April. And in terms of that non-exec recruitment, just to cover that off, it's been a really, really interesting process. We've had a large volume of interest in the 6 roles. And I think we have a confidence that we will be able to appoint to our non-exec directors in those 2 dates towards the end of this month, isn't it? When we are interviewing.
Yeah, absolutely. So I think talking to Sanderson, who have been helping us with this recruitment, this is probably the largest volume of applicants that they've seen.
Yeah, we had 61 applications.
Yes.
That one's very important, isn't it? 61's very important. Not that we're being competitive or anything like that, but 61. I'm just going to say that again, 61. Yvonne.
Thank you, Chair. So it's just a question really in terms of partner organisations. So NHS trusts and foundation trusts, primary medical services and local authorities. How do you see the voice of CICs and large community providers anchoring into and contributing to the board, and as opposed to the system ambitions as we move forward?
Yeah, so the 3 mandated roles, so primary care, NHS provider and local government, are enshrined in the Act. So until the Act changes, those posts will be required. And actually there'll be a real requirement to manage conflicts of interest around the table, because effectively you have providers sitting around a commissioning board. So we need to navigate that kind of quite carefully. The indication is they will come off in terms of the Health Act. There is the possibility that mayoral combined authorities will then kind of come in. So there was something about the board, but the other piece of work, and I think Teresa and I picked up this in our conversation, I think with our key stakeholders, has been that very much we're describing a board governance, but actually the ongoing conversations with our providers kind of informs all of the work. So the opportunity for providers to be involved in all the programmes of care. I think very much we've talked about the opportunities that we want to create to have the conversation with community providers, with our mental health providers, because actually those relationships are incredibly important. So I kind of think there is still an opportunity for points of influence in terms of the board. But actually we need to find a way to do that in a meaningful way that isn't about a seat around the table, because clearly this is about narrowing down the focus to a strategic commissioning board. So I mean, we could pick up in more detail, Yvonne, but I think we've certainly shared some initial thoughts, haven't we, Teresa, around how we might want that to look.
Yeah, I think there's a difference between, I suppose, the influencing the board and the operations and the way that we've sort of baked in partnership working throughout our new operating model. So I think the crux of the issue, Yvonne, is that the very different organisation we will be as a commissioning organisation, first and foremost, rather than the system leader, with having partners around the table to help steer that system leadership approach. So it will be fundamentally different. And as Jason said, once the Health Act changes nationally, we expect the board constitution to then change further.
Thank you, that's helpful.
Okay, thank you. And Michelle?
Yeah, no, I think to support your point, Yvonne, it's a really good question, and I think until the Act changes and we don't know what that's going to be yet exactly, we can hypothesise. I think it's really important to use some of the other structures we've got and have a look at those as well, Yvonne, like system leaders, the Friday coordinator, because there should be the groups, I think, as a provider that influence what's happening at board and within the ICB from a commissioning perspective and from a neighbourhood perspectives. I think that's up to us providers as well to sort of say, how do we use the collaborative structures that we've got to the maximise position that we can in order to do that. I'm not sure it's just necessarily a seat on the board. I think that's helpful but in the longer term, that's not going to be there anyway.
Yeah.
So I still think we need to do that work now, Yvonne, and I think that's the important bit, so that we then have that influencing ability to the board through different routes, if that makes sense.
And I think not, and I'm probably seeing Jane's Sund here now, and she's going to look at me with horror, but I think there's a number of things kind of floating around at the moment, one of which is the organisational structure, so the staff structure. There is something around governance, which is about the board, and then the next conversation, once we've kind of looked at the constitution of the board, is about board committees and what sits around kind of board committees, and I think we're working through that. I think we are still committed to reducing the number of meetings, but actually meeting when we kind of need to. So we need to understand what we have already and kind of what we need in the future. The other bit is that whole piece, which I think Michelle's touched on, which is around leaders forum, the things that we have already that are really useful, that still have a place within our future ways of working, that we need to then articulate what they're going to be kind of moving forward. And actually, I kind of think there's a usefulness in creating really an inclusive way of working, which I think we've thinking of right from the start. And of course, around all this is that whilst there will be a demandated integrated care partnership, we've given a really strong commitment that actually that partnership arena is going to be really important kind of moving forward as well. So we are committed that even though we don't have to have it, to actually having it, because I think that has become a really useful touch point in recent months for us thinking in stuff that we've done. So all of that stuff is in train. I kind of think there is something around when we've chunked it down, there's some different bits that we need to kind of keep moving. The real focus, and you'll understand this, the energy has been on the staff structure, but actually with an eye on the prize that we need to develop this other stuff alongside it. And we'd be interested in our partners and stakeholders' thoughts around what works for them and what could work differently. I think that would be really helpful. So any other questions on the constitution? Simon?
It links to, I mean, it's interesting that the contributions that you've had relate to partner organisations and representation. And I take everything you said, and the board isn't the be all and end all of all of that. Clearly, market development is a significant role for a strategic commissioner, which can seem very much like system facilitation. So I would just encourage the organisation to continue to see that as not only a legitimate, but one of the most legitimate areas, particularly as it links to primary care, community services, neighbourhood health, because that's the area where I think there is the most development needed, because it's the most, and I say this within where I'm sure people will understand, but it's the most immature part of the system in terms of provider development, coming from a history of 70 odd years of small corner shop businesses, which most general practice, for example, is, and to some extent a lot of the voluntary sector is, and bringing that together and integrating it into neighbourhood health with big players such as community trusts, mental health trusts, local authorities, as well as those elements of acute trusts that also provide those services, will be a key factor. And it's good to see that the latest version, or the final version of the structure changes recognised that important role in the slight amendments to the roles around neighbourhood health and others. So it's just a plea that continues to be a major factor within the role of the organisation. May not be described as system leadership, but that's really what it is, and it's a legitimate part of being a strategic commissioner.
Yeah. I think that's a point well made, and I think some of this, the opportunity we have, particularly around neighbourhood health, is about unlocking the potential that sits there. It's already there. We just need to see it and do something with it. Okay, so any other comments, or can we move to approve the constitution that's kind of presented in front of us? Okay, super. So your next one, Jane, you're on a roll.
It's Des now.
Is Des? Oh, it's Des.
Yes.
You've got a momentary pause. You're coming back. You're
I'm coming back in,
You're
yeah.
back, aren't you?
Yeah.
Go on, Des.
So this is just a really quick one. It's part of the standard rolling cycle of updates to the board. It's the standing financial instructions. Very few, just a couple of minor changes. One in relation to updating the limits to align with the provider selection regime and the procurement values. And a couple of small wording changes just to make sure that we've aligned everything to the scheme of reservation and delegation that we previously approved at the board. This has been through, well, actually went through Finance Committee as well as Audit Committee, and it's coming here just for noting. So everybody is cited from a transparency perspective.
Okay, so a housekeeping update. Okay, any questions, Des, about the housekeeping update? Okay, that's fine. Okay, so Jane, you're back.
Shot back to me. Yeah. So this is the quarter four governance review, committee assurance report. You've got a paper and 3 appendices this time, one around the committee effectiveness reviews, one around the committee annual report and the position statements. You will note, I think, in the paper that the committee of effective assessments have been done, but the actual development of terms of reference for committees we're going to do in quarter 1, 26, 27. That's because we're moving towards the shift towards strategic commissioning, but also our new non-exec directors will have joined us in April and they would want to be involved, particularly those that will be chairing some of these committees in the development of the terms of reference for it. So I don't think there's much more to say. I think the paper itself is really comprehensive. Happy to take any questions.
Okay, and I just wanted to say the amount of work that's kind of gone, I think, from the governance team, but also from those people who happen to chair or administer committees and the request for kind of information. It has been an industry, it's fair to say. But actually, you know, this is kind of what, there are still some to come, I think, which is, you know, for some other committees. But
due to the timing, the volume of work, there definitely is,
But I hope what people see from this is that actually committees are working effectively, that actually when we kind of look back at the stuff that has passed through our committees in the past year, that it's been a considerable kind of amount of work. And all of this then, Anya, helps us then move towards the production of the annual report. So this is part of that process around the annual report. And very much in terms of the areas and the recommendations, I think that are made as part of this committee effectiveness. I think, you know, we'll give merit and consideration to those in terms of such new committees, won't we? There's some useful stuff in here as well.
I would like to actually say a thank you to the governors, not just for this, but for the work they've done around the constitution in the middle of organisational change. I don't think it can be under-recognised. So thank you for recognising it, Chair. Okay, so are there any questions around the committee effectiveness? The bit that always kind of excites the interest more than anything else is attendance. I always find it's the tick list on attendance is the bit that everybody looks at. But clearly people are happy with their registered attendance if they're on a committee. So that's great, and we'll pass those thanks on. I'll email the governance team particularly and thank them on behalf of the board. Okay, so the next one is the Information Governance, Data Security and Protection Toolkit updates and audits. So this has got my name on it, but I'm assuming that somebody else is going to go through the detail on this. I can probably have it. I was looking at you, Nigel, at the corner of my eye. Did you feel that stare?
Yeah, I did feel the stare. Yeah. This actually goes back to one of our shared system priorities, as you might remember, which was about cyber and Defenders 1. And this is really key at the minute around where we need to be as an organisation, but going forward. So this talks about the updates and the audits that we will be doing around data security and protection. And in one of the section 3, it goes into detail about the areas that we will audit and look at in detail, and this is a requirement that we needed to do and that we will do going forward. But I suppose the thing that I really wanted to pull is cyber and defending as one across the system is one of our key priorities going forward that we've talked about in the minutes arising as well.
Yeah. And from memory with this one, there's a series of mandated outcomes which we have to do, and then we can select from a list the things that we also kind of want to do. I think this paper kind of articulates the three we've chosen, which is privacy and transparency information, secure configuration, and testing and exercising. And it's just to get the board approval that we add those to the list of things that will be part of the audit moving forward. Stuart.
I'm not sure if it's covered or not, but in other boards where I'm worrying about this kind of thing, we have an explicit artificial intelligence risk to manage with two sort of aspects to it. One, the possibility of data leakage if somebody is feeding private data into public AI tools. And the second one, which is AI from time to time, if it is used for efficiency reasons, comes up with a pile of rubbish. So the ability to spot errors in an AI-assisted process is in the sort of data worries that we're having in other places, and I can't detect it in these words. So that's the thought.
I'll have to go away and look into that. So I think that's really good.
Yeah.
Yeah.
And I think certainly if if it's not reflected in here at the moment, I anticipate that it probably would be in the future. But also, I think we recognise that risk, and that probably should be part of our risk register as well. So I think we can pick up on that as well. But that if we can just go and just check that, Nigel, and then we can come back and we can circulate something to the board just to get that. Okay, any questions about that one? Are we happy to approve the three areas that we've suggested are the new things that we want to add to the list? Okay, superb. So we're going to move on to the chair report. So I deliberately haven't written a report this month, not because I didn't have anything to do, but because I kind of wanted to just kind of do this month. But just to kind of start out, as most of you will be aware, Amanda Bloor has now left the organisation. So Amanda was our Deputy Chief Executive, Chief Operating Officer, been with the ICB kind of right from the start. And Amanda has communicated to staff in the past couple of weeks to say that it's her intention, or she has now left the organisation. So I just wanted on behalf of the board to pass on our best wishes to Amanda. Thanks for kind of being here right from the start and kind of setting stuff up, and to wish Amanda all the best for whatever kind of happens next. The other bit is, and this is a really I suppose kind of a keynote board, in that this is the last board in our current arrangements, and we've touched on that when we've talked about the constitution. As we move towards new ICB, and the constitution that we've kind of agreed today defines different membership for this board, and I've had the very enjoyable task, I think, the past couple of weeks of talking to most of you as part of your board appraisals, some reflection on how you've experienced being part of this board, an opportunity to reflect on things that we've done well, things that we could have done differently, but also the opportunity to talk about, if you're not in that list of people on the new board, what is the opportunity to continue to engage and work with the ICB, and we're really keen to do that. I kind of wanted just to kind of reflect that I think, this board has really led the ICB through some real positive times and sometimes a real challenge, and this board's been an absolute kind of constant in that. Your continued kind of commitment and enthusiasm to the work that we've been doing, it has been very much appreciated. And I kind of, was reflecting this morning that, this board has become sharp-elbowed when it needs to be. It has challenged very well when it's needed to. But also as a board, it's been very appreciative of the stuff that we have been doing through really difficult times. And actually, it has been a real partnership effort. So I want to thank everybody for everything that you have done in terms of this board. We will still continue to kind of work together. And actually, it's been a really nice time for me to be able to spend time with you, just to talk about the work that you've done on top of everything else that you kind of do. And I kind of, on behalf of Teresa and myself, the executive team, wanted to kind of say massive thank you. In particular, the last 10 months for me, kind of being in this chair, it's been easier because of the board around me, and I'm very grateful for the support that you've offered me through good times and challenging times as well. So it's a big kind of thank you. As part of that as well, today is the last board meeting for our two non-exec directors, so Stuart and Mark, who started this journey right at the start of ICBs. You were there on that kind of Thursday. And I kind of think, in the work that we've been doing recently around the role of non-exec directors, I think they are incredibly valuable around tables. The perspective they bring, the challenge they bring, the skills and knowledge and expertise of kind of different parts of life are incredibly important to ensure the board remains committed to its vision, the board remains on track, the board is connected to people and communities. And actually the non-exec role is a really difficult one, isn't it? I always call it eyes on, hands off, because actually you have to see everything and you have to be able to say, that's great, as well as, hang on a minute, can we think about this again? And I think you have done us proud in the roles that you've played. And in particular, Mark, that period when you unexpectedly then had to cover the acting kind of chair arrangement. I think we are grateful that you steered this board and this organisation through a period of real uncertainty, and I want to thank you both for the contributions that you have made to the ITB and to the board and committees that you have led as well, and the assurances you've given us. The other bit, just to, I suppose, to kind of note, is we welcome the appointment of Alan Downey as the substantive chair for Humber Health Partnership, and I think, I think it's a very positive move forward. And I know Lynn and I have spoken about this, that actually we have an opportunity to support kind of organisations, and actually the opportunity we have with Alan as the chair, I think I'm very much looking forward, Lynn, to working alongside Alan, and he and I have already had a number of kind of conversations, but I just wanted to say I think that's an incredibly positive kind of move forward. And that was the only thing I was going to share is that Teresa and I got to go out last week. We got to go to London, didn't we? To meet with. Now there is only 24 ITBs. You can't hide. People notice if you're not there. But Teresa and I went to meet with most of the other chairs and chief executives of integrated care boards around the country. And actually, it was a really useful session in kind of being able to measure where we are as an ICB with where other people are, because we haven't clustered. So there's still some, kind of clustering stuff kind of happening. My reflection on it is that actually we are in a really strong position as an ICB moving forward. I think how we've approached the new organisational structure, and that has been really difficult, has put us in a really kind of strong position. I think we're very clear around what we do and don't do kind of moving forward. I kind of think we have been very creative and innovative in thinking about how can we do more and how can we continue to do some of the stuff that has made the biggest difference in Humber and North Yorkshire. So I think we came away from that feeling quite reassured where we are, not naive enough to be that there aren't significant challenges, but actually it was a really useful touch point to say, actually, considering everything else, we're not in a bad position. And I kind of think the work we have done as an ICB up until this date, the past 4 years, is immensely important legacy work. Actually, that work has really informed what we do next. We will continue to do some of that stuff, so nothing has kind of been wasted. And I kind of think if we can retain that real commitment to partnership, collaboration, that enthusiasm from our partners, then I kind of think we can be that really strong strategic commissioning organisation that I think is certainly what's in my head, Teresa's head, and hopefully in your heads as well. The last thing I wanted to say is that now we're at that point, and Jane will touch on this in her update, around moving towards organisational change and transition. We will be seeing over the next couple of months valued staff from this organisation moving away from this organisation or moving into different roles. I didn't want to miss the opportunity to say thank you to those people because they have made a massive difference in terms of the work of this organisation. This has been a really difficult process, I think, for all of us, because this is ultimately not about structures, it's about people. So I wanted to publicly say thank you. I also publicly wanted to say that whatever the outcome for people is, wherever they go next, they go with our appreciation and best wishes. That's what I was going to say.
Yeah.
I think I'm going to cry. Never cry. Anyway, does anyone want to say anything before we move on to Teresa's report, which will be far more measured, and you've got a copy of in your pack? Go on.
Okay, thank you. So I'm not going to go through every item on this paper because it's there for, a lot of it is there for information. We will, however, republish this document because under section 3, 2 items have actually been merged into one and only one of the reports are linked. So the few areas I do want to update on. Firstly, in terms of the operational and financial plans, we talked about this at the last board meeting, but in particular, I just want to recap that we are coming to the conclusion of the planning rounds, ready to start the new financial year with those plans in place, which is something that doesn't normally happen in the NHS. Normally plans are still being discussed and developed well into the new financial year. So this is a very different period of time for us. And it is also in other ways a transitional year in terms of obviously from our previous responsibilities to our focus on strategic commissioning and the changing responsibilities between ourselves and the region, NHS England regional offices. Allied to that, we've got effectively the latter part of this financial year, we've had a reset of the financial rules that are being applied across the NHS, which for us has seen the loss of deficit support funding, which is obviously contributing to a system deficit. And therefore, there is a lot of work to do going into the next 3 years about how we actually address some of that with our partners. In terms of responsibilities, ostensibly into the future, the regions will pick up, if you like, what used to be termed the system control total. So the system deficit, the managing to that the financial plan as a whole. And ICBs are responsible for the alignment of budgets with individual providers. So I think we updated at the last board meeting that on the initial submissions we had a small amount of misalignment with two of our organisations at the time. We expected to close that misalignment gap with one of them. I think we are now optimistic that within the next 2 weeks we will close the alignment gap with the remaining organisations. So we will have agreed plans between ourselves and our providers across our system. We will be working with region and NHSE nationally around obviously some of the underlying financial challenges and how we actually meet some of the performance challenges that go hand in hand with that into the coming year. So that's all I wanted to update on that one. The second area I wanted to talk about was the Humber Acute Services Review. And people will recall that this was the changes across the North Lincolnshire and Gould site, born out of the sustainability and clinical safety concerns across a range of services. And the proposal saw a number of services consolidated on the Grimsby site and a couple consolidated on the Scunthorpe site. I think it's fair to say that there is a lot of public interest and therefore political interest in how these plans are now implemented. So I just wanted to signpost that there's active work in the background around overseeing that implementation, and that there will be a full update at the April board with a full agenda item on the implementation of this programme. The discussions that we've had recently, particularly with MPs and councillors, has focused around the need to make sure that there is active communication, both with staff and broadly with members of the public. So I wanted to make sure it was signposted in this report so that it's clear that we will be looking at it in detail at the April board, and there will be ongoing communication around it. I'm not going to cover the organisational change. We will pick that up under a separate agenda item.
Otherwise, Jane will have nothing to say.
Yes. And I just note where NHS England at a regional level are up to in respect of their changes. So in terms of national update, I've included some information around social care. And I think it's really important for us as an ICB to actually understand the perspectives of our partner agencies in particular. So the things that actually are, if you like, affecting them, the challenges that they have, some of which mirror our own challenges, but some we don't actually usually get the detail and the lens, if you like, through to actually understand particularly what's happening in social care. So the Skills for Care report particularly, I think is one that we need to make sure that the appropriate committees actually review and see what's important to note. And in relation to the ADAS review, we will take a look at that toolkit and see if it offers any opportunities, particularly as we work with our local authority colleagues. So the next item is the NHS mental health campaign. And again, just in terms of making sure that we support the campaign to ensure that people are urged to seek support for common anxiety disorders, and there's a link in the paper to actually facilitate that. Under the transition to the statutory gambling levy, the full letter is included as an appendix. I just wanted to include this to make sure that people A, were aware of it, and B, so that we can note that the regional lead ICB for specialised commissioning with which this sits is actually going to be North East and North Cumbria for our region. We will obviously work very closely with them, but we should note that it is North East North Cumbria ICB that will be leading on specialised commissioning for us in the future. Now, the next section is the section that we will have to get republished because somehow two items have been merged into one. So switch topic mid-paper, so not helpful. So we will republish this. But the first is the UK Parliament's report on the autism strategy and basically where we're up to and where we need to go next. And the second area is a number of reports actually, but there's one signposted particularly in relation to a neonatal death, and that's a coroner's prevention of future deaths report, and it's highlighting the risks in with utilisation of agency staff. So again, we'll make sure that the recommendations of that are picked up in the appropriate committees once we've got the appropriate links there. Equally, I'm sure people will have seen the publication of the National Cancer Plan for England and 30 specific actions identified within it, and a number of recommendations. And I think it's fair to say that as we look down those recommendations, a lot of those for us are in train. So I think we will pick this up through our normal cancer reporting, but it is a really important document and we needed to make note of it. The next is the bone cement, again, because of the national coverage and concern locally. But a regional process was put in place, coordinated across Humber and North Yorkshire by the ICB to understand our stock position. We did actually have some local supplies, and we have identified, I think nationally has been identified, some alternative products. So we do not expect there to be any long-lasting implications, particularly to activity and delays to treatment associated with that. And the final thing to say is about the NHS pay uplift. And really, it's only there to note that at 3.3%, linking this to previous rounds of industrial action, it is not thought actually to be sufficient to mitigate the risk fully of future industrial action. And that's the point that I wanted the board to be cited on. And that's it.
Okay. So any questions for Therese?
Only one detail. The national report on adult social care with some alarming statistics about people handing back contracts. Things. Would that be the same locally? Are we basically facing the problems outlined?
So for some of for things like the CHC that we would be doing commissioning in a similar way, I think there is a risk of that. It is much more profound, I think, across social care because of the scale of some of those contracts, and particularly some of the challenges that the sector has with really the rates of affordability, given how much local authorities can afford to pay. I think it's particular from my experience from charity that I support. It's particularly profound for supported living arrangements for people with learning disability and autism or mental health conditions living in the community. But we do experience it from time to time from some of the commission services for CHC.
And I think it's worth saying, I think one of the things that I'm very proud of, I think in the work we've done, Jane, through Breakthrough in the Workforce Board, has been that very strong relationship between the NHS and social care, and very much that one workforce agenda. And I kind of think I really welcome the Skills for Care work, because it has been a really interesting insight around career pathways, in terms of the move from social care to the NHS, a real opportune blurring of roles in social care. The pressure in social care, and particularly within social care providers, has been around not only increasing wages, but also cost of living in terms of heating and things like that. So actually the value of contracts are in real terms less than they were when those contracts were first signed, because of all those additional kind of pressures. And I kind of think it's something that I know Louise, from talking to local authority colleagues, has been a really live conversation between providers and local authorities in terms of, because there's a massive risk if these providers go, what then happens? So actually there's been some really active conversations around reviewing current funding levels. Nobody has huge amounts of money, but I think very much the really positive dialogue has taken place around what the opportunity might be to think differently around that social care kind of workforce and actually social care contracting. Is that fair, Louise?
Yeah, absolutely. Just from our own point of view, obviously we're the largest geographical council in the country. We've got to balance off rurality as well, and obviously getting people to work across the county, and what workforce challenges are very real. So anything we can do collectively, I think, is to be welcomed. And of course, we do await the Casey Commission on social care to see what recommendations may come from that. But of course, that's for politicians to decide, and in the meantime we need to just kind of manage what we've got between us. But it is a challenge across social care in terms of workforce, as it is indeed the NHS.
Can I just pick up? I think I mean there's lots to be concerned about in these reports, but for me particularly the structural concerns are the ones that I'm particularly, so the qualification rates falling. From an NHS perspective, when we're cash strapped as we are, we tend to think about actually in a triage situation those that need it most. So the sicker, those who need much more in the way of support, and actually potentially thinking that lower levels of support could be supported elsewhere, particularly by social care. But actually the levels of qualification are falling within social care, that might limit what actually can be supported outside of hospital settings. So I think there's real concerns for me in some of these structural issues, which I suppose doesn't come as a surprise to people working in social care.
And I know that's been a real priority, I think, for skills care regionally, has been around what the opportunities around education and training will be. Skills care did publish a really helpful kind of strategy about a year ago now, which I think kind of highlighted the concerns, but also said this is the opportunity you have as well. And I think there's a lot of positivity happening in social care as well. And I think, we have a really strong starting point in Humber and North Yorkshire because we have taken the approach we did around our workforce kind of piece. So, but it's worth keeping an eye on it. So it's a significant risk. Anything else for Teresa in terms of that? Okay. And then just to check, the risk of industrial action is still on our risk register, isn't it, for workforce? Isn't it? Yeah. That's good. Okay, so we're going to move on to you again, Jane. We're just giving you a little pause between things. So this is the kind of model ICB update. I suppose this is a reminder to the board that the board at its last meeting gave a series of assurances around the final structure, which we had shared with staff. And I think we've had an opportunity to talk to you quite a lot about not only the structure, but also the future operating model in terms of, we touched on it today, that different relationships kind of moving forward. So I suppose this was the opportunity, Jane, just in public, just to give us an update on where we are now. And it feels as though, we've talked a lot about 1st of April, very much kind of timescales are, it's fair to say, incredibly tight around this piece of work.
It's very difficult. I'm going to give the update in two parts, really. One, I'll just talk you through and give you assurance on the process so that you're conscious of where we are up to, and it gives the board assurance. And secondly, I'm just going to talk about people as well, because the people impact cannot be underestimated. So from a process point of view, since the last board, the people impact assessment letters went out as planned on the 13th of February. We opened the window then for appeals. The appeal window closed on the 27th of February, and we're in the process of hearing those appeals, quite a significant number of appeals. So the appeal panels met last Thursday, Friday, Monday, and again this afternoon. The VR letters went out as planned, about 7 to 10 working days afterwards. The appeal window for that closes today, the 11th of March. The appeals, we've got a number of appeals against the VR decisions, and the appeal panels for that commence tomorrow. So in summary from that, we're well on with the plan that we had. Slight slippage on the appeals against the people impact assessments, a couple of days slippage, so it's minimal really, but there is a little bit of slippage for you to be aware of due to the volume and the complexity really of what is in those appeals. So stage 1 slotting, which is what came out of the people impact assessment letters. So people have had letters already confirming. We've had 1 or 2 errors in some of the letters, which has changed the output of that for individuals. We've dealt with those errors now. We knew there would be some with the volume and speed with which we were doing the letter writing and also the content of that. So, and then the ring fencing, which is where we've got more than one person for a role, but they are all still a 70% match to the job description. That is imminently due to commence, depending on the output of the appeals, because we need to know what the impact of that is first. It's a very complex and difficult work. So from a process point of view, we're on it. And I can give the board full assurance about where we are around that. From a people impact point of view, though, this is the most difficult period, I think, compounded by how long it's taken to get to that point. But we've got large numbers of people, some obviously slotted in, and therefore they know what their future holds at the moment. But also a large number of people that are in still a state of flux about what this means for them, and therefore are suffering with real periods of anxiety. And, our occupational health referrals, for example, have increased quite significantly over the last few weeks. So I think a couple of things to say. Don't underestimate the impact that this has on people. We are all feeling it, no matter what our role is in the organisation. We are all feeling it. We're trying our hardest to lead with professionalism, and I know our people are doing the best that they can in the circumstances that they've got and keeping quite difficult work going. But I do want it recorded formally, the impact that that's got, and probably also, without a doubt, the impact it's got on the HR team, who are a small team, deeply impacted by the changes. 60% reduction in that team through the ICB changes, and yet leading this change. So huge thanks to them for keeping all the show on the road, I have to say. Incredibly difficult. It's a really emotive time. and an important time for the ICB. So yesterday, as an executive, we met to start looking at the transition plans, and we're looking at how we involve our workforce in those transition plans, and with more to do on that in the next week. So in summary, really, I can give you full assurance of where we are in the process, full assurance on developing the next steps around what that transition looks like, but real challenges and difficulties for our people, which we should acknowledge and understand.
Okay, that's really helpful. Any questions, Jane? Mark?
It's not so much a question, but I just think Jane's point about the not underestimating the impact on people affected and the people instigating the process and working it through, right up to, the people sitting around this table should not be underestimated. So I think, thank you for highlighting that. I think it's really important that you did.
Okay. So just check the board. So there's assurance there in terms of the process that we are currently undergoing at the moment. And then there is that acknowledgement. And I kind of think there is the impact of this, I think, cannot be underestimated. And there is something about the individual impact, but also the teams who are managing this. And actually, the volume of work that's kind of been happening, the people who are kind of, hearing the appeals, actually, it's a significant kind of piece of work.
I just had one more thing I wanted to add at the end. Our union colleagues as well are working significantly hard, because obviously for a lot of individuals, they will go to those. So they come to HR, but they also go to the union colleagues. We've got good, strong union relationships, but they are incredibly busy.
Thank you. Okay, superb. And there'll be further updates as we kind of go. Okay, so Anya, so we've touched on already today the importance of the voice of lived experience in terms of our future commissioning. It's been a key element of the work of this board, kind of right from the start. And the power and impact of the things that you have brought to this board have really been, have been really kind of have massive kind of impact. So we're going to move on to, so today's theme is 111. And I must admit, I had the experience of phoning 111 the other week. And I have to say, what a fantastic service. They asked me all the right questions and told me to basically pull myself together. It's quite good. Sorry. Fair enough. Isn't it really? It's not to get me in A&E, but to pull yourself together, take a paracetamol. But anyway, so Spotlight on NHS 111. So I think you've got, as always, Anya, a video for us. And it isn't me saying pull yourself together. Although, so handing over to you.
Thank you, Chair. So a slightly different voice of the lived experience item today, but I think actually very pertinent. One, because some of this insight was presented to the board almost two years ago. And so it's helpful to summarise some of the work that's taken place since, and I think also highly relevant to our future direction as an ICB and some of the things that we will need to consider moving forward. So I'm going to take the brief report as read, but just a few things to pull out before we go on to the short film, which I think will bring this to life much better than I can. So going back in time a couple of years ago, and colleagues that were around the board table then may remember that we did quite a significant piece of engagement and insight work to understand views and experiences of 111, because this started from, I guess, a bit of a working hypothesis, if you like, that if we could get more people to use a more central triage point rather than expecting them, particularly in what for them is an urgent or emergency situation, to make that right choice on where to go. We could have a better customer experience in directing the patient to the right place, or to the chair's point, perhaps they don't need a service at all. They just need some reassurance that they don't need a service. And also the feedback, obviously, from our providers in the main, that again, for them, it would be really helpful if they didn't just have people turning up to services, that it was a more managed approach. But you can see, as a reminder from the headlines of that insight 2 years ago, there were significant disparities around the awareness of NHS 111 amongst members of the public and their intention to use it and their satisfaction from those that used it. So at that point in time 2 years ago, just over half were satisfied, which also obviously means that approaching half were not satisfied with the service that was being received. And there was significant variation in terms of the awareness of the services that were available through 111. And at the time, the overwhelming majority were only using 111 telephone. They were unaware of the opportunity to use that digital services as well. So that's just a reminder of where we were a couple of years ago. Again, I'm not going to go through the report, but you can see that over the period of 2 years, there has been more general engagement and awareness activity, and specifically some more targeted activity with particular practices. And you can see in the report that particularly last winter, we'd identified practices where the patient's attendance rate at ED was high and where their NHS 111 use was low. And again, there's some interesting points in there that I won't go through today. But I guess in summary, and I'll come on to the film in a couple of minutes, what we have seen over the 2 year period, and this has also been supplemented by more general central national campaign work around 111, is again much more of the feedback that we're getting is that people are more comfortable and confident in using 111, and crucially their experience is much more positive, and we'll come on to that in a second in terms of the video. So I will just conclude before we move on to the video that clearly there is still a lot of work to do, but I think there are some signals here that using 111 as that triage opportunity, if you like, does have merit. There is gain from that. Again, it might not be a one-stop front door triage point, but absolutely there is significant opportunity there, particularly in making sure that the person gets to the right service and it's a more managed rather than reactive response. So you can see just at the end of the report in terms of the recommendations, obviously this insight will move through our programmes of care, but again it's that idea of how do we continue to promote 111 as that effective digital front door or wider front door for people, to continue working with our colleagues at YAS who deliver the service to capture that insight and intelligence and continue to capture the public and patient experience and insight to improve not just the 111 journey, but how we're seeing this is a critical part of what I would call it an end-to-end customer journey. And again, in some of the case studies that you'll hear on the video, you can see that sometimes while their experience at the front end might have been really positive, again, some of the elements of that customer journey, again, there is room for improvement. So again, work to do, but I think some really helpful learning points in this work. So without further ado, Chair, I'll go to the film if that's okay.
Good morning, you're through to the NHS 111 service. My name's Milo. Are you calling for yourself or for someone else today?
Yeah, my name's Milo Foster. I'm an IUC health advisor over at 111 in Wakefield.
Yeah, my name's Nav. I'm a health advisor from Wakefield 111.
Good morning, you're through to NHS 111. My name's Lindsay. Are you calling about yourself today?
So we work on a basis of ruling things out. So we have to rule out life-threatening conditions first. So some of the questions that we ask might not be relevant to what you're ringing about, but it's so that we can get you the right care and the appropriate service for what's going on.
We can send you to, like, for example, chemist. We can sometimes book you in an appointment at your GP. There's different walk-in centres, so it's not always in an emergency department.
I think that the saying, I think especially what people use emergency 999, non-emergency come through to ourselves at 111. But again, if you're not too sure, give us a call. You know, I think when you give us a call, it does go through the little script of if you've got chest pains, heart attack, signs of a stroke, go to 999. Or you'd be surprised how many of those come through to ourselves. So yeah, I think if you're not too sure, yeah, come through to 111. You know, we'll always be able to take you through an assessment and give you some help. So.
We're a great service. We can help people, and you know, there's nothing more satisfying than when somebody rings and you actually manage to like get them an appointment somewhere, and it makes you feel like, you know, you've tied up that loose end for that patient. But you know, you can ring us anytime. I mean, some people do get misconceptions in that they think we can diagnose over the phone. We can't. We're an assessment and signposting service. So if you've got symptoms that need assessing, we can do that for you, and then we'll signpost you off to a service that's appropriate for what's going on.
So it takes a lot of pressure off other services, for example, emergency department, GP, things like that. We can triage you and signpost you to the right place.
I'm Linda, 82, and I live alone. I recently had to visit Scunthorpe Hospital emergency department twice after a stroke last September. The first time when my eye began bleeding, NHS 111 sent me to the hospital, and although it was busy, staff were expecting me. An eye clinic appointment the next morning confirmed it should heal naturally. A week later, severe pain returned, and again 111 notified the hospital ahead of my arrival. An ophthalmologist was available, and I received treatment and medication to take home. Across both visits and services, 111, the ED and the eye clinic, I felt safe, supported and well cared for, which meant a lot living on my own.
I was admitted to Scarborough Hospital as an emergency after feeling unwell and struggling to urinate. NHS 111 advised me to attend the urgent treatment centre within 4 hours. I arrived at 10 AM and within an hour I was moved to a ward, put on an antibiotic drip and diagnosed with sepsis. I spent 4 days in hospital receiving antibiotics. Throughout my stay, every member of staff was attentive and professional. The care was faultless, and I felt fully supported during what could have been a life-threatening situation.
I contacted 111 twice last winter due to my husband's worsening respiratory symptoms. While the initial questions asked helped, the callbacks I received repeated much of the same information, and I was advised to take my husband to hospital myself, without being asked whether I was physically able to do so. When I explained that I wasn't able to do so, I was told to expect a long wait for an ambulance. In the end, the paramedics arrived very quickly, and they were excellent. At the emergency department, my husband was seen promptly, but the 8-hour wait was uncomfortable for him, with little privacy or updates. Overall, the staff were very caring and professional, but better communication, attention to comfort, would have improved the experience for his time in the emergency department.
My name is Marie, and I recently had to take my daughter, who has epilepsy, to the emergency department after she suddenly developed breathing difficulties while on antibiotics. During the NHS 111 call, her symptoms worsened, and we were told to go straight to the hospital. When we arrived, she was quickly triaged and given adrenaline, which improved her condition. We later learned she had had an allergic reaction to penicillin. As a nurse, I know how pressured emergency care can be, and the clinical treatment was excellent, but the experience would have been less stressful if the receptionist team had been more approachable and communicative. Small gestures and updates can make a big difference to worried families.
I'm Ashley, 62. On the 22nd of January 2026, my life changed. After feeling unwell at work, I left and returned home when I developed arm pain and chest tightness. I called NHS 111. A first responder arrived quickly. He told me I was having a heart attack. Minutes later, I was taken by ambulance to Leeds General Infirmary, where a team was waiting and fitted 2 stents immediately. The next day I was transferred to York Hospital and discharged after 4 days. I've since returned to Leeds for further assessment and I now require a heart bypass. It was frightening, but the fast coordinated response from 111 to the responder to the paramedics and both hospitals undoubtedly saved my life.
You'll end up at ED if the answers to the questions deem that as the most appropriate service for you. We can never say when somebody comes on the phone what that right service is going to be, because it is all dependent on the answers to your questions. Sometimes as we're asking the questions, we might ask you extra things to determine you're giving the right answers, but wherever you end up will be appropriate for the symptoms that you're displaying at the time of the call.
Obviously things that a doctor can do, doctor can't do. If you've broken your leg, we're not going to advise you to call your doctor. You know, there is things that typically it's going to be a long way, we understand, but again, it is urgent. We either need to get you seen in a hospital setting instead of more of a doctor setting. So yeah, if you do need to go to A&E, very important, very vital.
Thank you. Thank you. And to everybody who kind of supported the production of that kind of video, I think a really valuable service in terms of 111 and that feedback as that one point of contact to get that advice and navigation through the system. I think is incredibly important, isn't it, in the challenges that we all face. Mark.
Yeah, I was like these bits, but I like that as ever. Andy, just one question it was interesting. There was a comment in there about the use of 111 online as opposed to making a phone call, and I know that was from the previous time, and it was referred to as we went through. Do you think there is sufficient understanding out there that 111 and the NHS app and the use of online contact through that kind of blend, if you like, exists? Because I can't help but think people definitely think of 111 as being something you can phone, and they get that there is an NHS app. I'm not sure how well understood it is, particularly amongst those groups of people who would tend to go to online as their first point of contact, that it is, that they can do that online. I don't know whether we're able to comment on that.
I can certainly comment on that, and I think it's fair to say it is still very much work in progress, because I don't think in a number of cases people do either understand that or indeed that there is the ability for some people to have that seamless service through the app. So it's very relevant actually, and it links to one of our previous conversations around the work with the Deaf Centre in Hull. We actually, as an action from that, very recently, a workshop was facilitated at the Deaf Centre to support members of that community to use the app. And while it was really helpful, what soon emerged was that the functionality that was available to some individuals, particularly through their GP, wasn't switched on. So their ability to have that seamless journey, whilst they understood the opportunity, it just wasn't possible for them. So I think there's a lot of work to do. And I go back to what I call that seamless customer journey, both in terms of the digital journey and also then again what you saw on the film and the experience that they actually have across our services. So I think it's fair to summarise as work in progress, Mark.
Thanks, Andy. And from very recent memory, I think it does give you the option of the online when you ring, and it kind of says if you want to access services online, we can send you a link to your phone to kind of do that. So. And I think very much this is that whole part of that development, isn't it, of that future way in which we access and use services, and that increased focus on a new look NHS app is around how does this make navigating the system easier and better, and very much that whole philosophy we have around that future like shift around in the movement from hospital to community is about saying our investment in prevention and community-based services enables hospitals to be hospitals and GPs to be GPs rather than actually being the catch-all for stuff which probably doesn't fall within the remit at that particular time. So I kind of think all of this together very much is the cornerstone of the 10-year plan, as it's the analog to digital bit of the 10-year plan. So, and thank you to everybody who's working in 111. I spent half a day there a couple of years ago, and the volume of calls and the range of calls that people were receiving, the way that they're handled in such a sensitive way, and people are handheld to the right service for them. I take my hat off to them. I think it's a very pressurised environment. The sheer volume of calls going through shows, the quality of the service that they are delivering. So thank you to anybody who is using 111, and in particular the person who told me that I didn't really need any treatment. I just needed to pull myself together. I didn't say that. It's my interpretation of it, by the way. Okay, I'm here now. Simon.
So it's just one quick thing that we just need to be slightly careful, I think, about mixed messaging with regard to 111 call use in relation to GP practices, because part of our organisation regards high levels of in-hours 111 as a sign that a GP practice is potentially struggling. Or even failing contractually to provide that immediate assessment in emergency situations. Clearly different in out of hours, because in most parts of our patch, NHS 111 is the first line of contact for out of hours primary care, but in hours primary care. So it was interesting that in the slides about the focus work on practices with low 111 use, admittedly with the high urgent care use, is that if that's in hours, in some parts, I've done quality assurance visits to practices where that's been one of the reasons that's triggered the call, as opposed. So there's something about us just being clear whether we're saying it's a good thing and we want to encourage use of 111 versus whether we're actually wanting areas with high 111 use in hours to look at their own practice level access. And I think the answer lies in your answer to Mark's question earlier, which is a lot of this is about integration. So as lots and lots of practices move to providing an online offer around immediate triage, for example, to allow the practices to do that signposting, filtering and arranging direct appointments. For those that choose to do that through the NHS app or through NHS 111, that needs to be joined up, because at the moment we're still in a situation where people choose a digital solution and then get almost told to revert to an analog solution to get the right signpost. And that doesn't make sense. So work in progress is exactly right, but we just need to be careful about that mixed messaging, particularly in relation to primary care access.
And I think it's that curiosity about data, isn't it? Data tells us one thing, so we need to understand it, we need to ask some questions, we need to kick it around, then we need to, and I think very much, that whole emphasis on data moving forward as an ICB is about data as a starting point, it's not necessarily the end. So we need to, be really careful. Push for that.
More than that, it's about actually what does good look like? What do we actually want? And as a commissioning organisation, we need to be a lot clearer about what is it arrangement to achieve here.
Yes, I think that's right. And I think, can I go back to the fact that actually this is about the best outcome for patients, isn't it? So the best outcome for patients may be something different to what they started the call expecting, but actually that expert, however that is done, takes that person to the right place. And I think this is all about outcomes for people, isn't it? Better outcomes for people, and actually enables the system to do the stuff that it needs to do for the people who need to have that bit of the system. So that's really important. So thank you for that.
I was just going to say, could I just conclude by formally thanking the patients that took the time to share their stories and experiences with us, and the colleagues over in Wakefield that took the time out, as you say, of their busy schedule to help us with that film, which is also being used as an education engagement tool.
Thank you. So we're going to move on. So we're going to go from 111 to what looks like it's a brief kind of touch point update. And I'm assuming, Sean, you're going to take this one, which is the update on the plans to mission for 2026-27. This is here for information and noting, not for decision, which is why I think everybody can remain in the room.
Yeah, it's just a summary of really the deadlines and where we've got up to at this point in time. So there was an initial first draft plan was submitted in December. The final draft, well, not draft, the final plan went in February the 12th. We were working on those agreements right up to the deadline. The morning of included the plans had to go in for 12 noon, and we were working right up to the wire on getting those in. This is a very brief summary about where we've got to and how we've achieved that. But what I would say is this planning round, compared to the previous two that I've done on this patch, and I've been planning for a number of years now elsewhere, we had a lot more engagement with providers this time round. In terms of it, we still use the collaboratives to support and get messages out. But essentially, we had from mid-October onwards, we either had monthly meetings with providers or weekly, and by the end of the process, we were down to almost daily meetings with providers. For assurance to this board, those meetings were at exec director level, so very senior engagement in the process. And to support those discussions, the likes of myself and finance team were meeting with our counterparts within providers to try and make sure that what we were discussing made sense and where the challenges were being made. So where did we get to? In the main, it's a 3-year planning submission in terms of numbers and performance trajectories. Where we've got to is delivery of the performance asks by year 3 across all of our providers, with the exception of diagnostics. So diagnostics needs further work. There is significant improvement over the 3 years in diagnostics, but we haven't quite got where we need to get to, and that, so we'll need to work through that with our commissioning intentions, our transformation work, and across sector discussions. But there is significant improvement in that area, I must stress. In terms of the other indicators, dependent on the organisation, some are delivering in year 1, others get there on a journey to year 3. Notably, it is the cancer challenge and the 4-hour challenge. So where we are at present is deemed too far away for some of our providers to realistically achieve that in year 1. So year 2, there's some of them come online. Year 3, it takes for one of our providers to get there. But essentially, we get to the required performance by year 3. In terms of financial delivery along that, the agreements in the plan obviously have a significant financial challenge. I believe, and I'll hand over to Des, that we've got where we need to get to in the majority of our providers. We're still having negotiations with one of our providers around getting where we need to get to.
Thank you.
Add to that on that finance.
I think that what you're mentioning is in terms of contract alignment. So we're aligned on 4 out of our 5 providers with conversations ongoing with one of them. In terms of the provider positions, I think in the paper nods to this. Several of our providers have got deficit plans, and that conversation happens with region. That is not with us to resolve.
So, and I think probably Teresa has kind of picked up the tail end of this. So I think what's happened next subsequent to this, and I think it's a really useful kind of overview for the board of where we got to from the original sign off of the plan to where we then got where we are up to now. I think Teresa helpfully then in her update has kind of talked about what subsequently kind of happened. It feels as though, as always, planning is a very, very long kind of process. But actually, I think there's a key point in what you've talked about, I think, Sean, which is around the different way we have approached planning this year. I think very much reflects a different organisation, how planning kind of fits into a strategic commissioning context rather than a system kind of context at the moment. And I think that's really important. I think that's been a real adjustment for us as an organisation, but also an adjustment for providers in terms of that approach. And I kind of think that's been useful at this point in time.
I think just as a point of note, I mean, one of the elements of the financial reset is obviously a move away from block contracts.
Yeah.
Which is why the alignment piece is really quite important.
Yeah.
Sorry, Sean. The only thing I would add really is that there was extensive work in our commissioning intentions that ran through this. You've all heard about them in previous papers and so on. So that's our future delivery model, again, aligned to the new world of this organisation. And just a point of reflection, and many people who are on the call are aware of these discussions. I think there will be a kind of a summing up, what could we have done better piece of work once we're absolutely over the line. And I think that would be welcomed by our partners who work with us on planning. And one of the areas that I think it isn't about doing better, because I think people were working as hard as they possibly could on this, but it is the interface across sectors where there is probably potential to improve planning and improve performance and finance discussions. We had to have the provider approach this time, but I think going forward, those interfaces is where the opportunities lie, and probably we need to build that in better.
And I think that will be supported by the programmes of care, because that's where the interface will happen on a routine basis. In
the future. And I really welcome that. And I think in any look back, as long as you create a very small space to say, what did we do well? Because actually, on top of everything else in terms of organisational change and everything else, and the amount of time the challenges the clients are under, devote the time to planning. And it wasn't just one meeting. But actually, I kind of think there is something about we got to where we needed to get to. There's still more work to do. But actually, any look back has to say, despite all of that, we actually had some really, really challenging conversations, for the ITB and also for our providers. And we got to the point where we have a plan kind of moving forward. So let's not lose sight of that. And look back sometimes aren't always about things that haven't gone well. They're also about, actually, this wasn't bad. Okay, and thank you for all of your work on this as well, Sean. I can imagine. I can imagine that you haven't had much sleep.
This time of year, been doing it for 30 years.
Yeah.
I like to kick back and smoke cigars and drink port in June.
Can I just say that's not health promotion advice.
Balanced by a healthy salad, Louise Wallace. We're having a healthy salad whilst kicking back and drinking port. And I'm hoping, Sean, that was a slightly discreet invitation, but we'll pick that up outside of the meeting. It's my birthday in June, just saying. Okay, so we're going to welcome Simon. We're just going to do the last item before we get to you. You've joined us a moment where I'm hoping, as the chair of our finance committee, you're not slightly alarmed about how we're reacting to planning, but we'll pick that up separately. Okay, so the next one, Deb, are you taking this one?
The performance.
No, the property.
Property, yes. It was a.
If not, we can ask Jane, because Jane's covering everything.
Jane's had more than her fair share, hasn't she? This is in response to guidance that came out at the back end of January in relation to the potential ability of some of our NHS providers to take back properties from NHS Property Services where it makes strategic and financial sense for them to do so. There's a set of rules around it. At the moment, we are at a stage of expressions of interest, but under the guidance, that window closes at the end of March, and it requires a board decision from the ICB because of the timings and the fact that the next board is only in end of April. What we're asking for in this paper is that board delegate that authority to sign off the expressions of interest to chair and chief executive, so to Teresa and Jason, just in the interests of us being able to sign those off. I just need to reiterate they are only expressions of interest at this stage. There's no requirement for a formal decision. There's some due diligence that will have to go into those expressions of interest, and there is a set of guidance to which we will have to work in terms of the things that NHSE have set out. As I said, it has to be strategic, it has to make commercial sense. There are questions around, the viability of organisations taking on these responsibilities. So it only applies, the ICB sign off of these only apply to those organisations that are in NOF 3 and 4 and 5. So those in NOF 1 and 2, NHSE will make those decisions directly.
Yeah.
So it was just to ask or to get board permission to delegate that authority when those expressions of interest come in at the end of the month.
Yeah. And there's nothing definite at the moment. I think it's just that provision for the charity big exec to do that on behalf of the board. Sure.
So I'm sort of wondering what criteria we're going to apply. And there's some hints in the paper, but it'd be interesting to hear a few more comments on that. And the other thing that has got me worried about this is we presumably inherit any liabilities that go, or whoever takes it on, the provider who takes it on, inherits any liabilities such as knackered buildings and delaps and all those kinds of things. So can you have
Indeed,
some comments on those?
it's an ownership responsibility that transfers, so it's everything lock, stock and barrel, which is why it needs to be a commercial decision around the viability of what we're taking on. We are still working with the NHSE steward, to be fair, to get an exacting list of those criteria, because we've got some question marks back and forward. So if the expressions of interest we get in at the 31st of March are not sufficiently filled out for us to even be able to assess against the guidelines as they exist, are we able to work beyond that? And the answer's been yes, we can continue to consider that. There is a decision point nationally at the 31st as to whether there's enough expression of interest for them to take this forward or not nationally. So it might, you know, if there's not enough interest nationally, they may not proceed with this at all. So I think this is very much an exploratory, would people be interested in doing this at this stage, as opposed to us saying, yes, definitely go ahead and do this. I don't think we're at that stage.
If I might, what's the advantage to the provider of having this building as opposed to
not having to deal with NHS Propco?
Sorry, quicker decisions.
Well, not just that.
That's helpful clarification, Dr.
I mean, this is slightly parochial as a GP in Whitby, I would say, but so I'm sure there are lots of examples, not just at Whitby, but there lots of providers, I think, have found significant issues in terms of working with Propco around decision making and around costs. And I think that certainly from a neighbourhood health development point of view, there is huge potential in removing that, frankly, obstacle to the best use of buildings. That's not to say that due diligence doesn't need to be carried out, and there will be financial implications and all the rest of it that come with the liabilities. But the potential prize is that this significantly increases the flexibility of NHS estate, I think. And in the past, where I think there have been issues with relationships with NHS Propco in terms of decisions made, the flexibility of use, as well as the high levels of cost associated with Propco leases, is that the NHS appears to have had very little power, influence or leverage with it. This potentially is the government looking at a way of, I think, unblocking that, or the NHS blocking that. And I would strongly support those organisations that are in a position potentially to be able to take this on, to please look at it with the future of neighbourhood health, if nothing else, in mind.
Yeah, and I think that's a really good point. I think this is about what the opportunity lies in, but actually acknowledging that there's a sold-as-seen element and there is a risk around this as well. So actually, which is why it's expression of interest, isn't it?
Last one from me, I promise, on this. Does it also bring the ability to change the property we're using? So can we get rid of properties and buy properties once that original unit is in our command? Because if we're developing a neighbourhood health and we take over property which is fit for what we used to do but not fit for future purpose, can we sell it and buy another one someplace else? Is that how it works? Or
I haven't got into that level of detail, to be honest with you.
We can ask the question.
So there's a flexibility in decision making. It's just the end game is, if you run it for a couple of years, you think it's under your control and it's not fit for future purpose, then you need to be able to make changes.
Let's go back and ask the question.
Take clarification, but I mean, the intention would be is where, for example, if an organisation is 100% tenant in a building run by somebody else, if they get the ownership for it, then maybe they take on the ownership right. So it would stand to reason that what you're suggesting would be right. But we would, I mean, I haven't seen the technical details of how the underwriting contracts will work and what they're actually.
And I'll raise it because given all the changes we're envisaging, you can imagine wanting to change the properties you do it in.
Yeah. And I think that there's also that whole thing about how do you balance that drive to do new builds with actually making better use of what we have already. So the one estate bit is the conversation that every 3 years comes round, where we have conversations around one estate and we go, what can we do better with our estate? There's a point where we just have to do something with our estate and not keep reviewing our estate, to be honest, because the pictures don't look any more attractive 3 years down the line. Michelle.
Thanks for that. I need to declare an interest, because obviously an NHS organisation, from a provider point of view, we are interested in some of this process. So please make sure that's noted.
Yeah, can we make sure that
And obviously won't make any decision in relation to the approval process. But just to sort of reiterate, I think what everybody said, what you said, Chair, and what Simon said, it's about that flexibility. It's about using the properties. And as being a resident in NHS properties, it is really cumbersome. One, it's exceptionally expensive.
Yeah.
So that prohibits a part of the issues, for example, we've got with the floor spaces. Nobody wants to occupy the floor space because of the cost. So that transfer will be a lot more facilitative, I think, to developing the neighbourhood models, things like diagnostic centres in a different format, etc., etc. So I think it's exceptionally positive and something that a lot of providers have been pushing for a long time in relationship to. Yes, Stuart, there will be some liabilities, but that comes back to the board, the relevant organisational board.
Understanding that,
due diligence, but I think there's a lot more benefits in relationship to that, and it will be done hopefully in spirit with the community and the strategic direction of the community as well.
Yeah, there's a purpose to it. Yeah,
it's local ownership, I think, which is at the moment it's just an arm's length body that's just.
Okay, so any other questions on that? Are the board happy to note that kind of update, but then also give the delegation to myself and Teresa on behalf of the board to do what we need to do by the end of March if we have to do it, and then we can report that back. Okay. So we're going to go on to, as always, the snappiest title of anything on this agenda, the integrated performance report with performance, quality, workforce and finance. Pause. So I'm conscious, Simon, how long are you with us for? What's your cut-off point?
I've got to go at past, Jason, unfortunately.
Okay, so what I'm going to say is let's do finance first, whilst we've got the chair of the finance committee kind of in the room. And then we'll kind of then flow through the performance stuff, which I'm assuming, Sean, you're going to cover, the quality stuff, which will kind of sit with Amanda, and the workforce stuff that sits with Jane. You have to speak for about 20 minutes, so you obviously need to speak at some point in this meeting, Jane. So should we, we've got the copy of the paper here. I think this is about the highlights and this is about the things that you need to alert the board to as we kind of go through. And it would be useful, I suppose, once we've had the finance overview and Des, Simon, if from the point of view of the finance performance and contracting committee, you were able to kind of come in with the covering off discussions that certainly Teresa and I have been part of as part of that committee. So, Des, over to you.
Thank you, Chair. I wasn't proposing to spend too long on this. The update is broadly the same as previous months. Our provided trajectories continue as they have been with the in-month deterioration of around £11 million a month adverse movement to plan. So as at the numbers of month 9 in your pack, there was a £56 million adverse variance on the provider lines. The ICB position remains broadly in line with plan. I think the most significant update compared to what we were talking about last month, we signalled that providers would be able to change their forecast outturns, and we were expecting that to happen. We can now confirm that those forecast changes did go in at month 9, and they've gone up with discussion with NHSE. So the providers, if you take away the deficit support funding, are forecasting around an £86 million adverse variance to plan. If you include the deficit support funding, that drops to about 70 million. So it's a significant adverse movement this year. We have been signalling that in our risk and mitigation schedules all year. So the number that has gone in is consistent with the number that have been flagged. So there was no surprises against the numbers that were put in, and the drivers for that are well rehearsed. I think that there's one of the significant points to note on the report as well was one of the drivers is around the delivery of efficiencies in the providers, which is forecast to be £53 million behind plan to the end of the year, which will have a significant impact into next year and is driving some of those adverse variances into those adverse deficits, or those deficits even, into next year in the plans. So it's a continuation of the same theme. The drivers continue to be the same. It's confirmation that those the expected forecast changes did go ahead in month 9, and the risk into next year.
Okay, super. Simon, anything you want to?
Well, yeah, thanks, Jason. Yeah, so I think the key thing for the board is the position in the providers going forward. So we've got a really significant deficit in the providers, and that is going to impact in terms of commissioning, strategic commissioning going forward, because it's of such a scale. There will need to be some sort of commissioning response to that in terms of how services are organised as part of a medium-term sort of financial recovery plan for the patch. Okay, so and I would expect that there would be, a regulatory response to the position from NHS England, and that sort of medium-term sort of planning piece involving that. How we're going to organise services in an affordable fashion is going to have to be a big emphasis, I think, of the work of the ICB in the coming year. Yeah.
I think that's right. And I think, we're flagging this as a significant risk, I think a current risk, but also as a future risk as well. I think that's a really important point around what the legacy of this will be moving into next year. Any other questions around the money? Okay. Looking disappointed, Des. We can find some if you want. Okay, so looking at this, Sean, you're not going to be much more cheerful in terms of performance, are you?
Thank you, Chair. I'll try my best. Are you going to pull the slide?
Can we put the slides on, Carly?
I'm not going to go through every slide. And what I would stress, and I think I said this last time I was with you all, this is a fairly blunt measure in terms of how we're measuring performance. Performance is much wider than this. This is very specific around the success criteria that's set out in the operating plan. These are monthly figures, and when I go through some of the ones that I want to pull out, I will give you a little bit more context to them. At the moment in time, I'm working with other people on the annual report as well, so I've got a little bit more information on some of these rather than it just being a sea of not where we want to be in terms of delivery. Can we just move to slide 4, please?
Okay. And by the way, Emma is with us today, so we have Carly, who is operating the slides today. So welcome, Carly, and thank you for operating the slides. We couldn't do it without you.
So orange is bad and blue is good. So this is the making data count recommendations that we don't use red and green. That we use these visually. It's more helpful to people. So it looks like that the top half of that chart that you're looking at there are all secondary care indicators. Where it starts to turn blue is where we're looking at indicators out of hospital. And we're looking at this over a period of time. So we're trying to show you how, rather than just giving you a 1 month position, this gives us a flavour of how things are going over time. So we look at that and we can clearly see that from the end of Q1, the June position where we were reasonably healthy in terms of blue, we see that from a secondary care perspective, so these are targets such as referral to treatment, 18-week performance, 4-hour performance in ED, cancer performance, those sort of indicators. We have not hit those indicators since the end of Q1, whereas the out of hospital indicators that relate to proportion of primary care appointments seen within 14 days or a large amount of mental health indicators, MHLDA indicators, we see a more healthy position against planned targets. So looking at that, it's not where we want to be. These are performance against planned targets that were agreed in the annual operating plan. So just like the process that we're going through now, we're agreeing next year's plan. These are not being delivered as we'd like them to be. What I would say is if you look into the detail, and I know visually it's not easy on screen, how you see, you're not necessarily seeing a worsening of position. What you're seeing is just a consistent delivery against a plan that was planned to improve. And we're not seeing the improvement that we wanted to see. If you just skip forward 2 slides, please, you'll see the urgent care as an example on that. So 4-hour performance in the top left, and then it's 12 hours in department in the middle, and then it's ambulance response times to the right. What you're seeing there, if you take the one on the left as an example, I know it fluctuates and it improves and worsens, and that's because seasonally, as you'd imagine, there are certain times in the year where it's easier to hit 4 hours than others. And so we fluctuate. But actually, if you take that back over time, what we're seeing is just a fairly consistent level of delivery. Since I arrived here, it is basically operated from the 63% to 70%, and that is the numbers that I have seen throughout the 3 years, 2.5 years that I've been here. So we fluctuate, but we're not seeing any long-term improvement. However, the dotted line at the top is what we planned to see. So we were hoping to see, and we had actions. People were demonstrating what they were going to do in and out of hospital. We have programs, but what we haven't seen is that performance improvement. But what I would say, and I'm not, that is the performance, and we had planned for it to improve. So I'm not making an excuse here, but the reality is the number of people that we are treating, the numerator and denominator, are over the number last year, and they are over planned. So more people are using these services, more people are using A&E, and from a volume perspective, more people have been seen and discharged within 4 hours numerically. But as a proportion, it is not happening at an improved rate. So we're not hitting the target, but more, it is not, it's a blunt measure to look at it and just say, oh, well, everything is not where we want it to be. More people this year than last year were seen and treated and discharged within 4 hours across our providers. But as I say, there was a plan, and that means we haven't achieved what we thought in the plan. I'm not going to go into this level of detail on everything, but if you just skip forward to the elective care one, I think it's 2 more. That one, yes. This again typifies on the front sheet. We saw orange against plan. In terms of RTT, this is the 18-week statistic, the performance percentage. The top left-hand corner is our RTT performance. It is just flat. We are not seeing improvement. We're not seeing increase. However, record numbers of completed pathways have been done this year. So we are stopping more calls. We're doing more work, more RTT pathways than ever before. However, it is not improving the performance seen within 18 weeks. But what I would stress to this board, again, you don't see the level of detail that sits under this. In terms of, it would be wrong to take from this slide and think that all of our patients are waiting long waits across all specialties. What we're getting down to now is there are certain pathways, there are certain specialties, there are certain groups of patients who do wait longer than we want them to be, but a lot of patients are seen, treated, discharged within 18 weeks. Very few patients numerically are getting to that 52-week position. We wouldn't want to see that, but in terms of delivery against plan, we're not where we want it to be. And then the last one I wanted to show is the cancer one. Just go forward 2 more, I think it is. So what we're seeing on here, again, I know it fluctuates monthly, but at the top left-hand one is the 62-day standard, the key target in cancer care. We're not seeing improvement. It fluctuates. We're just seeing, if you look at the average across that, a fairly consistent cancer 62-day performance. But again, within, and if you look at the providers under that, you can't see it from this distance, obviously, but we've got the providers split in there. And Huth, if I pick Hull out, Hull are our lowest performing provider in this space. However, if I look at the volumes of patients that are treated, initiated on new cancer pathways, Hull has increased its number of new cancer treated patients by 770 compared to last year. Last year, there was 2,000 up to this point. 2,100, I believe it is. It's up to nearly 2,900 this year. That is, I don't like using the word significant without having done a statistical test, but I feel fairly safe that a 770 increase in the number of new cancer-initiated pathways at Hull Hospital compared to the previous year, year to date, is a significant increase in the provision they've put on. However, unfortunately, a number of those are waiting longer than when we want them to do, and we're not getting the performance improvement. They have stepped up the capacity. It's that second chart that I believe where we need to focus in terms of the cancer discussion, and that is the 28-day faster diagnosis service. We're not diagnosing enough patients within 28 days that is going to then allow us to meet that 62-day standard. So as a blunt measure, we are not seeing delivery against plan in secondary care where we want it to be. We're seeing positives out of secondary care in terms of mental health delivery and primary care delivery. Within that secondary care metrics, We are seeing greater numbers throughput. We are seeing numerator and denominator improvements, but still concerned that we're not delivering the planned levels of targets that we wanted to do. All of this has been wrapped up in the discussions for next year, and some of the delivery plans for next year, we're going into a lot of detail around some of the actions that will need to be taken.
That's really helpful, and I kind of think just reflecting on the walking through deep dive stuff that we've done as a board, you know, over the past few months. We've walked through all of those kind of areas, and I kind of think the one around the cancer stuff, I think we, the board, shared the view that actually that meeting that 28 days was the really key bit, because if you don't meet 28 days, the rest of the pathway then becomes impossible to deliver. So actually the emphasis on that 28 days and around taking out those patients who didn't need to be in the pathway through that process, and then focusing on the patients who did, and then the rest of the kind of the targets, you know, was certainly, you know, where the board kind of got to in that conversation around cancer. I think that's been really insightful and useful, Sean, I think, in terms of understanding. So any questions around the performance stuff? So we're coming to quality in a minute, Amanda, so get yourself ready. Yeah. Mark.
So just want to say, Sean, I thought the way that you described that was really helpful as well. So thank you for that. Just going back to the ED performance, I know you'd said that the volumes were higher than plan. Could you give us a sense of, I don't know, are they 50% higher, 2% higher? If you don't have the exact number, just a rough view would be.
I'm imagining he's got the number.
I think got the number right. In terms of urgent care, it differs by provider, as you'd imagine. And for me, the main one to me is not the plan, it's from last year.
Okay.
So I think from last year.
Comparator,
Yeah, so we can all plan for more, but the plan may have had some assumption in it that we agree or we don't agree with at the time. But if I just give you the numbers, for example, so type 1 attendances, which is the key measure for they're the most challenging ones. Huff, for example, have had 5,000 more patients this year, so about 4% increase this year in terms of its type 1 attendances to last. Harrogate have increased on their type 1s, and so have York. But the biggest increase is that whole type 1 attendances. And conversely, what they've also seen is a higher number of admissions.
Yeah.
So that's the challenge that they're seeing. But overall, 7,500, majority of it at Hull, 7,500 increase in our type 1 attendances this year.
Over a total of what?
Oh, out of. So the 5,000 at Hull is out of 92,000.
Okay.
And the 7,500 is out of 350,000.
Thanks. So they are. I think you'll be justified to use the word significant. Stuart.
Thank you, Sean. Well done. The use of volume statistics that you've just been doing does bring it to life. I just wonder whether the report shouldn't contain, next to the various statistics, we've already got some volume stats of the kinds you've been using to illustrate what's going on underneath these stats. That would seem a useful enhancement to me.
Yeah.
And not very tricky given the thing.
I think we've got an opportunity, haven't we, we've started that journey, I think, this year on looking at what that combined report around these areas kind of looks like. Remember, at one point we used to get all these things kind of separately. I think we've still got an opportunity to refine and to kind of think about what's really useful to kind of put in here. And actually some of that, the question then says, what actually is the piece of work that needs to happen with the patient population that actually addresses that significant kind of increase? Because actually, if we think about the 111 stuff, we think about neighbourhood health, actually how much of those additional people need to be in an emergency department, and how many of those people actually, if we follow the direction of travel of the 10-year plan, actually would be taken out of the system to the right place, which is somewhere else. And I kind of think there is an opportunity to do some working through in the context of the new world as to what we want this report to kind of look like. I think there's almost an embarrassment of riches, and it's about working out what's the really useful stuff that really drives that change and improved outcomes. I can see you thinking about that now.
I think there is some of that information in the paper in this afternoon's meeting.
Yeah.
But whether they should all come together in one report, I'm happy to.
I think we need to explore the possible, don't we?
Yeah.
Michelle.
Yeah, thanks, Chair. First of all, really well presented, and I really like the way that it was presented, because it was like that holistic piece about demand going up, and I think it put it into a bit of perspective, because sometimes we just see the semi-raw data and it's a bit more stark. So I did like that that commentary, so thank you for that. It was mainly an observation, I think, more than anything else, and we'll probably hopefully pick it up later. But I think given your explanation and some of the data pathways, it's really important that from a strategic point of view, we look at how we start to work through that neighbourhood profiling and the pathway work. Yeah. Because it's clearly that demand is going up. We need to look at that preventative agenda. That does take time, so we've got to be patient with it. But also that we need to start to really look and start to really make some difficult decisions, I think, in relationship to that pathway, and how can we really help improve some of these figures? Because as you say, they've been like that for a long time. Yeah. It's a bit about like, well, let's just bite that bullet and knocking some dominoes down to get those pathways and those intersections in relationship to conditions better, because they will have a positive effect. But it's not about the performance data; it's about the difference we make into people. Yeah, to staff, isn't it?
Absolutely. I think it's right. I was on a really interesting call yesterday, which was about how health inequalities drives use of our services. And I kind of think when you highlight some of our most challenged providers, they're in areas of high health inequalities. So actually, what's the opportunity there to tackle health inequalities in a meaningful way, rather than just saying we're doing so for health inequalities? So in some ways, this is the foundation bit. This is the legacy piece in terms of what we do next, kind of as an ICB, and actually how do the levers of strategic commissioning and that work with our providers that we've described in our new model enable us to understand the solution. And I think I once said around this table, we are very good at articulating the problem. We need to be equally good at articulating the solution. So we need to take this data and do something with it. We need to take this data and together think about what are the things that we kind of need to do. So I think this is exactly where the conversation we need to be having around performance, and this is the real performance, and there is that consistency. We've seen this month on month. So it's not a blip, it's the real position, and that's what we kind of now have to work with, which I think is incredibly important. Any more questions for sure on the performance bit? So Amanda, was there anything on quality you wanted to throw in this as well?
A few. I'm conscious it's in the afternoon.
Yes.
Pack, isn't it?
So you might just want to tease us with a bit of quality.
Just give you a few headlines. So just following on from the performance conversation that we've just had with Sean, is the question that the team are starting to ask, and I've asked them to look at, around the impact of poor performance on the safety and quality of patient experience and outcomes. And that's specifically around that diagnostic piece. Sean and I had a conversation around it. When you look at some of our providers, there is a significant issue around the diagnostic backlog and what impact that has specifically around our cancer pathways. And Sean's talked about the faster diagnostic standard, the impact on urgent and emergency care in terms of receiving care in temporary escalation spaces, and what we are seeing playing out in some of the data, particularly around pressure ulcers, hospital acquired, category 2 and 3, and deep tissue injuries. Infection prevention control clearly continues to be a real challenge for us across our patch, and the chief nurses and I have agreed that that will be a priority. Suffice to say, we still continue to see poor compliance with infection prevention control practice, and the IPC team that sits with me are continuing to report that back. And under there also, we need to look at falls with harm and time critical medicines. So that's the performance piece, and very much linked to what Sean has just shared with us. Maternity, it's just to note, Chair, that the AMOS report has come out. There are no surprises within the AMOS report. This is the maternity review by Baroness Amos. It's the same themes that we have seen in just about every other maternity report, bar one, which is interesting, which is the estates piece, and that's in the context of seeing a change in the nature of birth and the profile, and that's going to need to look very different going forwards in terms of how maternity units are configured, just in terms of building, because of the changing need. We've rolled out the maternity outcome signal system across the patch. That's the MOS, that's safety alert through the intrapartum piece, so through birth. We've had a couple of flags which the team are picking up with the individuals. It's probably worth noting, just in terms of that health inequity piece, We have some of the lowest breastfeeding rates. We've got some of the poorest rates of smoking cessation at birth. We've got relatively high levels of gestational diabetes. So there's a lot to go at across our piece. The SEND white paper is coming or has arrived. The team are working through what that means for us, and we are working with partners, our local authority colleagues, to really think that through with the new plans coming into place. I did want to flag, and we can have a conversation later around Jessie's rule being rolled out in primary care, and this is where people attend 3 times with similar symptoms, and that stop piece that needs people to think differently. And I think it's very much linked to confirmation bias and what we learn from what people's behaviour and seeing that. So I think there's a lot to go at. We've talked about vaccinations and measles. Nigel's made reference to that. And then, of course, it's the regulatory action that we've got going on across our patch at the moment, and the fact that 3 out of our 4 providers are in escalated oversight. I'll leave it there.
And we can make a bit more detail, and it would be useful, I suppose, for a future board that wants that kind of assessment of what the SEND white paper means in terms of that relationship we have, you know, with local government around SEND, to useful just to understand. And I kind of think, you know, that there is an opportunity there to build on the work in that space, but almost to give that new world context.
Yeah,
which would be useful.
Particularly, I think, linked to the mental health and the ADHD conversations that are happening, because that's driving now a lot of the SEND requirements. So
and it's how we join that up through that new structure and the purpose of the care is that important. Okay. Last but not least, Jane, workforce.
Yeah, short and sweet, this one, I think. So compared to last month, we've had an increase in workforce overall. We're at 285 over, driven by one particular provider. So the other providers are more or less on plan. Agency continues to reduce. That's been a good news story last year and this year. And I think Des touched on this quite a few minutes ago now, around the pay bill continues to increase. So not much more to say. The growth is in the substantive area, which may be good news, because increasing your substantive might reduce even further some of the agency costs. We'll see further as we get to the back end. Probably also worth pointing out for the board that the workforce board, where we manage some of these risks, will no longer exist in the new world. That's finished now. So there is things, I think, and I'm sure they are thinking about this from a provider point of view, how they manage together some of the key component areas, but we won't be supporting it from an ICB anymore from 1st of April.
Okay. Any questions for Jane around the workforce stuff? Okay, so the board notes that report. Thank you for the huge amount of work that goes into kind of producing that, and actually, I think that is getting to the point where actually we're getting that really real-time kind of position of the challenge, within our system, and particularly the challenge from the point of view of organisations, but also the bit around who's taking this back to patients who are, when we're talking about these numbers, we're talking about people, and it's increasingly people that we know that we are talking about. So I think that's incredibly important. Okay, I'm going to move on to insights reports. So we've got quite a lot of them, just moving towards end of year. So I'm going to take them as read, but I'm just going to ask people from those committees just to, there are a couple of escalations to the board, which we do need to note within these as well. So we're going to take them the order of the pack. So I'm coming to you first, Mark, with the Quality Committee on the 18th of December. You've got 3 things listed there.
Yeah. So one of them I think is largely mitigated now, and that is that we had a significant concern that Healthwatch, the disbandment of Healthwatch, left a gap in terms of patient voice, which we needed to fill in a different way. But our understanding is that the funding for Healthwatch has been extended by a further year. So that will come back as a concern potentially in another year. But that's no longer a critical issue for us. Second one was to do with the Valdo Calicane review, independent review recommendations, which we've looked at in the context of what we are able to do in the patch. And there are gaps that are not able to be filled in short order, I think is the important thing to say. So there's still work to do around that, and that remains a challenge that we wanted the board to be aware of. And then the third one, which links back to the conversation we've just had, really, is the risk around maternity and neonatal services, but specifically the reporting system, and the fact that that's quite fragmented, and that presents a risk that we could miss issues which we clearly don't want to miss. So again, we need to put some work around that. And as it says there, things like cultural issues are also a part of that. So they were the three things we wanted to highlight, that we will continue to, or someone will continue to address in the committee, but for the board's information.
Okay, thank you. And just on the Health Watch one, I mean, Amanda, you and I were part of a really useful kind of session with the Humber Health Watchers that was kind of looking at what the opportunity would be in the future around independent patient voice. And I think it was, you know, we were able to, I think, talk about certainly how we see patient voice moving forward. And I think we've touched on it throughout this kind of meeting today. But actually, we did recognise, I think, in that meeting with Amanda, that there is a gap in terms of some of that independence of Health Watch. And actually, you know, we are keen to have an active kind of discussion around what might additionally we do in that space. I mean, you can't have too much engagement, and you can't have, you know, too many different mechanisms to kind of be talking to people. So there's a work in progress that we kind of need to pick up. And I think I'm conscious that we probably need to balance that with the conversation with the North Yorkshire element of Health Watch. But I think that whenever that happens is a very real risk. Okay, so there's risk there. So you get another go round. But in your meeting of the 11th of December, you didn't have any critical risks to escalate because you've done them all in your previous meetings. So that's quite good. So I'm coming to you now, Stuart, with audits. So your meeting of the 15th of January.
Yeah, a couple I don't think we need to dwell too long on. One was a concern, there's two raised as significant. One was a concern over levels of training in conflicts of interest areas, which just needs monitoring and improving, frankly. And the other you've already really covered, because we were worried about the fact that the audit committee chair was about to step down. We didn't quite know what was going to happen next.
So what we have done with audit in particular is, so we are retaining one of your independent members to provide us consistency in the lead up to June. So we will be being aware of that in some of our thinking around committee membership. So thank you for those. So Simon's not here, but there's nothing to escalate from finance, performance and contracting on the 20th of January and the 9th of February.
No.
I like the way you sneak two meetings into one form.
There were three.
Quite
Yeah.
three. Then you've got another one on the 2nd of March.
Yes.
No escalated with critical risks. There's one for me and you, Anya, which is the ICP Partnership Steering Oversight Board, and there are no critical risks for that. There's one for me and you, Jane, around the Workforce Board, and there are no critical risks for that. Children and People Start Well Board. So I'm going to come to you, Amanda, in terms of this one. So there's a couple of critical risks. I am worried that there's no risk register.
Yeah, so can I just give you a list? So I haven't been to the Start Well Board, but we had a conversation, Mark, didn't we, at Quality Committee about where it should report. It's envisaged to be a committee on the same as the others. This was enough. I'm glad you said that, because that's exactly never envisaged to be part of a board.
I mean, this is here, and whatever status this has in the new structure. Let's just look at the.
So we're going forward of a reference group in the future. It will be the equivalent to. Yes.
Yeah. Okay. So there's a couple of critical risks there, but we're going to review the role of this thing.
Yes.
Okay?
I'll pick up the critical risk with Michelle. But it will be picked up in a different form.
Because they feel slightly operational rather than strategic.
They are.
All right. Okay. And last but not least, Nigel, rescue us from this one. We've got no critical risks. Thank you. Is there anything you want to say about that? Your critical professional group?
No, there's just one thing that was escalated, which is about the commissioning optimisation programme. However, there are mitigations in place, and especially with the new ways of working, where that will sit. And there are some sort of key areas that we will need to really push on with clinical productivity around 4 key clinical areas. So that will continue, and it will link into the new ways of working.
And some of that piecing together of the structure that kind of sits alongside and kind of sits underneath kind of the board committees will be around recognising there is some stuff that we still need to do. We just need to find a home for it. you know, and actually,
So the commissioning optimisation programme is part of our efficiency
programme, isn't it? So we need to make sure that we are prioritising that. Okay. Any questions for anybody on those insights reports? No, we've clarified the Start Well board is a operational group rather than strategic group.
Yeah.
Okay. Okay, so item information. So you've got the link to all of the good news briefings, which I very much appreciate those kind of being pulled together around you. There was no any other business that anybody kind of flagged. I think my only closing remark would be is just, you know, for the final time in our public meeting in our current form, thank you for everything that you are doing. Actually, I think as I kind of think about what happens in April, you know, we have done some absolutely amazing stuff, and we've spent far too much time, I think, you know, talking about things we haven't done, targets we haven't met. And actually, I don't want to lose sight of the fact that actually what we've done as a partnership and a collaborative over the past 4 years has been some pretty amazing stuff. Our problem is if we don't shout about it. And I kind of think about some of the brave decisions this board has made. Some of the, you know, some of the stuff that we've done in this ITB, and I think around the People Story dashboard stuff. I think some of the workforce piece. I think some of the work we've done around quality, some of the work we've done around commissioning, you know, a lot of the work that we've done through that whole partnership approach has been a really valuable kind of diving board, springboard into where we go next as an organisation. So that commitment for us to work in partnership remains. The commitment for this board to have connections, and the whole future world, I think, is about connectivity, and it's about relationships, and it's about people. So actually, thank you very much for everything. We convene again this afternoon. But to anybody, member of the public who have joined us or has kind of lasted the course, thank you for your ongoing interest in our work. It's kind of very much appreciated. And we will see you all again at 1 o'clock. And now I move to close the meeting, excluding the press and public in terms of the nature of business we now need to conduct. And thank you. Thank you.